So what is weight loss surgery? Weight loss surgery is a tool that is designed to help control appetite. It's not a miracle, although in many people it does work in a very miraculous way to really change the whole way that they relate to food in terms of having control. But it's not a miracle by itself. It does have to be used properly, like any tool. The two tools that we use surgically are Roux-En-Y gastric bypass, which is sometimes called just the Roux-En-Y or sometimes just gastric bypass. Sometimes it's also called stomach stapling, but as I'll mention in a few moments, there are other procedures that are also called stomach stapling, so that's a little bit too broad of a term to really be specific enough for what we do. And we also do laparoscopic adjustable gastric banding, which is the lap band that is made by Inamed, or now Allergan company here in the U.S. There are some other adjustable bands around the world, and we may have some more in the U.S. soon. This is an illustration of the gastric bypass. Allow me just to point here. This is the stomach, the body of the stomach here, and this is where the esophagus comes down and normally joins the stomach. This is a small part of the upper stomach that we divide off, and I want to point out that currently we divide the stomach off, and we've been doing this throughout the life of our program, but formerly in older gastric bypasses that was not divided, and people who've had gastric bypass many years ago sometimes can have that re-established connection. If you hear of somebody who had a gastric bypass that opened up or grew back or had a fistula, you can hear. So we divide that bowel, divide that stomach off and make a little tiny pouch. And then we bring this piece of bowel, was down here connected to this, we divide the bowel down here and bring that limb of bowel up and attach it to this small pouch. That is jejunum, is the name of that part of bowel. So that's a gastrojejunostomy if you're reading on the web or in a book. And then, since this stomach now comes down to this, what was a dead end, we bring that together with the bowel down here, and that's the Y part of the Roux-En-Y. You can see here that digestive juices that are made in the stomach and the liver and the pancreas here come down and then join food at this point in the Y. And now food that you swallow comes down, and it doesn't have any digestive juices to help it be absorbed until it gets to this point in the Y. And that's why we call this a malabsorptive and restrictive approach. That small pouch is a restrictive, obviously you don't have as much room to swallow food or to store food. You feel full much quicker. But then it's also partially malabsorptive because those two limbs up above now really are not absorbing much food. It doesn't actually make a whole lot of difference in the number of calories that you absorb. Down below you still absorb most of your calories, but it does make some difference in terms of minerals, vitamins that you absorb, and so you do need to be on a supplemental vitamin for life. The advantage of gastric bypass over other methods currently used, first of all, it really is the gold standard in the United States, and it was the gold standard previously in the world, and I think it's actually coming back to still be the standard. I think there are more bands being done other places in the world for various reasons, but this is still the standard even worldwide. It is fast weight loss. Usually in the first 6 to 9 months people lose most of the weight that they're going to lose. Some of the disadvantages of gastric bypass, though, are it is a bigger operation than the lap band, and there are some being bigger operations where we're dividing and sewing bowel more, we're having more things that have to heal, we're in more places in the abdomen to reroute these bowels around. There is a higher risk of things breaking down or not healing properly. So the mortality rate overall, the death rate with this operation is about 1 in 200. In centers of excellence, it's about 1 in 300, but it's along the lines of hip replacement or a little bit more than gallbladder surgery, but along the lines of any major surgery. You can have, with gastric bypass, malabsorptive problems, usually related to vitamins or minerals. Some iron or anemia can be a problem for some people who need to be on a supplement. Dumping syndrome is a problem that people can get when they swallow, especially like a milkshake, a food with a high osmolar load, and it doesn't have any storage in the stomach anymore. It goes right into the bowel, and the bowel brings fluid into that lumen, into the inside of the bowel, and you feel like you're light on fluid, like you just lost you just are almost instantly dehydrated, and that causes people to sweat, have a fast heart rate, and just feel generally sick. I don't actually call this, it's not really a complication or a disadvantage to me, and for most patients they are glad to have that, because they generally get dumping with naughty foods, if you will, things that they probably shouldn't be eating much of anyhow. And a lot of people will tell you they can have a bite or two of ice cream, but if they have a bowl, they will get that dumping, and that reminds them that they shouldn't be probably eating that much ice cream. Possible anemia problems, we'll touch on complications of surgery. That certainly can happen. The adjustable gastric band is a purely restrictive approach. The only thing that happens, and this is a band right here, this is the top part of the band that goes around the stomach. You can see here it forms a very similar pouch to the pouch that we divide off with gastric bypass. However, we don't actually divide any tissue, and we do sew a little bit of tissue, but it's not something that would leak for the most part if the stitches were to break down. This tubing comes out and sits under the skin. It doesn't come outside of you at all. And there's a little port, this is a reservoir that sits under the skin that we can access in the clinic with a very small needle, with a little numbing medicine. It's a very easy little procedure to do, easier than an IV, easier probably than a lab draw. And we can either put fluid into this system, and that inflates a little balloon on the inside of that band, and if you come to the information session we pass a band around and you can see it in person. There are also some very good resources on the web that are, we have links on our website for that, that you can see how that balloon looks. But that balloon, as it increases in size, makes the opening from the pouch into the main stomach smaller. That holds up the emptying of food and makes you feel full much quicker. Both operations are designed basically to make you feel full on a very small amount of food. And that's where we talk about control of appetite. Advantages of this, first of all, the band has been around for more than 15 years. It's been approved in the United States now for more than 6 years. It does have a lower operative risk. The mortality is about 1 in 1,000. It is reversible. First of all, you can remove the entire system, but that is still an operation. It is also, though, reversible in terms of its effect by taking the fluid out of the band for many people. If you need to go on a mission trip to Africa, or if you need intensive medical treatment for some other reason, or with pregnancy, we can back fluid out of the band as well as put it in. There are no malabsorptive problems. You do have a shorter hospital stay. Usually people can go home the same day with the band. You don't have any dumping issues, and again, for some band people that can be a little bit of a challenge, because it is easy, as you can imagine, to sneak high-calorie liquid foods through that band and you really don't feel full, and that requires a little more motivation to avoid those foods than with the band. And you generally don't have anemia issues. It is a longer-term weight loss. It usually people are more than a year. Many people are even more than 2 years before they reach their lowest weight. However, most people are losing weight from almost the very beginning. They just lose a pound or two a week, as opposed to several pounds a week that we can see with gastric bypass. The other disadvantage is that there is less long-term data, just because the band has not been around as long, and we don't know if there will be issues over time. Other weight loss surgical procedures that have been done, and some are still done. Vertical banded gastroplasty is the old stomach stapling technique. I don't have an illustration of it here, but it did basically what the adjustable band did in terms of just creating a little pouch with a small outlet. But the outlet was not adjustable, and the way that the pouch was created, everything could open up over time, so that the tool essentially was either not there at later years, and so people regained weight, or for some people, with just a single non-adjustable opening, they would learn to eat around that, and they'd need a little more control or a little more help. And while it was very effective weight loss in the short term, at the 10-year mark, about 40% of people had regained their weight. There are a lot of people out there who have very successful weight loss with a VBG, but certainly with this degree of long-term weight loss, it's not an operation we want to be promoting, and we don't perform it because we think the lap band has better outcomes, at least in the time horizons that we are aware of currently. Biliopancreatic diversion or duodenal switch is a pair of operations that are very similar. They're not exactly the same, but they are very, very high malabsorptive procedures where you actually are not absorbing all your calories. And that does mean then that calories that someone with one of these operations ingest, when they ingest calories, they're actually pooping out some of those calories in the end. They go through your colon. As you can imagine, when you're actually pooping food products out, a lot of people do get diarrhea with this, sometimes 6 to 10 very loose, foul-smelling stools a day. Their gas doesn't smell great to begin with, but their gas often can smell more like rotting flesh because of that food. But beside the sort of grossness of what can happen with this operation, the malnutrition risk is actually very much higher, and we don't think that for the additional weight loss there's really much benefit for patients. This really is the most severe operation there is. And I would like to just point out for one moment, there are people who come in who say, this is really what I need. They've read about it on the internet, and I don't think it's an irresponsible operation. It just has more cost than the other operations. However, I think a lot of people worry that they are not going to feel full after the other operations, and they read about BPD or duodenal switch, and they hear that they can eat as much as they want, and they're not going to have to eat any less. And while that's partially true, I think it's more because they don't believe that the other operations will work for them, that they won't feel a satiety or a feeling of fullness, that they'll feel deprived with the other operations, and they won't feel deprived with this. And really that's not the case. With the lap band and with gastric bypass, you don't feel deprived. You feel like you've had enough food. And I tell people, you know, if you like pizza and you can tolerate pizza, and sometimes people with the band can't tolerate the crust, but the idea is for you to feel full after one piece of pizza or even a half a piece of pizza instead of full after 5 pieces of pizza. It's not that you can't enjoy food, but I do think sometimes people choose this because they're concerned that they're going to feel deprived with the other operations. We don't perform either of these operations here. Now, I do want to stress again that no operation is a cure. These are treatments, and they are very effective, and they do work very well with motivated patients. I'm always a little scared to use the word motivation because everybody, I'm sure, has told you every time you've dieted, if you were just a little more motivated. This is not that level of extreme motivation where you have to be deprived and where you have to summon up a tremendous amount of willpower. It's more the motivation that it requires to use glasses every day, or to keep them clean, or to keep your car running and remember to take care of it like it needs to be taken care of. It doesn't mean you have to become a mechanic. The same for these. It does not mean you have to become a perfect eating person. You don't have to follow a perfect diet. You don't have to become a perfect athlete. We do recommend, obviously, for long-term success that you eat responsibly and that you do try to be active every day to move your body. I'll get into that a little bit more, but it's not as hard as all as dieting and keeping things off. However, even though it's not a cure, it is a very effective treatment. Very few people fail to lose weight, especially with the gastric bypass. There are a few who fail to lose weight with the band. It just doesn't give them a good signal, or they just aren't ready to use it, and that does happen rarely, but occasionally. And very few people ever regain all of their weight. Now, we do have some people who regain some. Almost everybody with a gastric bypass will regain a little bit of their weight because they lose a little bit of muscle in the first 6 months of weight loss, and they regain usually 5 to 15 pounds of muscle mass. But very few people regain all of their weight. However, as an Australian surgeon says, it's not automatic. Americans, especially, he likes to pick on us, says that we really want things to just be fixed. Doc, just fix me, I don't want to think about this again. Well, it's really not the case. It's not automatic. You do have to use it. You do have to wake up every morning and say, well, this is how I live my life, and I'm comfortable with that. I'm glad I did it, and most people are. It's also not risk-free like any operation that we perform. and we'll get into the risks a little bit later here. This is the weight loss curve. This is a graph of what can happen with band and bypass on average, and with duodenal switch operation or biliopancreatic diversion. As you can see with the band, the diamonds here, the weight loss happens over 2 to 3 years. Certainly most of the weight loss comes in the first year, but there's still substantial weight loss in the later years as well. I think of this as an advantage in several ways because it does give you more time. It forces you over time to change habits. If you're only halfway to your goal after 8 or 9 months, you're more likely to keep up with your walking program, to keep up with support group, to keep up with making good food choices, and that reinforces being able to do well for the rest of your life, especially with Minnesota or Wisconsin winters. Finding out Plan B or Plan C type exercise activities and practice them over a couple of winters is definitely a good thing. The gastric bypass, as you can see, people lose a lot of weight very quickly, and they stabilize at a little less weight loss. Usually they regain just a little bit of weight. This on average is about 10 pounds in years 2 and 3. A lot of times people panic that they're regaining all their weight, and that's almost never the case. Now, we have on here, for completeness sake, the duodenal switch operation, biliopancreatic diversion. You can see there's more weight loss here long term. However, again, as I mentioned, at the cost that we don't believe is really worth it. This, for most people, is 10 or 15 pounds additional weight loss at most. Certainly somebody who's 200 or 300 pounds overweight may lose 20 or 30 pounds more, but there's not much health benefit in this difference. If you're diabetic or have sleep apnea, your problem is usually dealt with by the time you've lost 20 or 30 pounds. And so we're well into a safe zone with all of these operations, and more is not better. It's attractive, it sounds like a better deal, but again, in terms of the risks that go along with that, it's just too costly, we feel, and most of our patients agree. Revisional operations, we do perform here. People who have had older operations, either an old gastric bypass that has broken down, or a vertical banded gastroplasty, or other procedures, we can change a VBG to a gastric bypass. We can add a gastric band to a previous gastric bypass. Some of the old bypasses had a larger gastric pouch, and people do get benefit from having a band on that. That's a very individualized issue, and we definitely go into great depth with people who want to have a revisional operation in terms of defining what operation they had, what their current anatomy is, what their expectations are.